Good afternoon, everybody. So I'm going to be talking for the next half hour to give you a little bit of a flavour of some of the issues around mild traumatic brain injury and post-concussional symptoms. As Mike has very kindly already highlighted, there are issues around some definition, which I won't spend a huge amount of time sort of talking a bit about, but just so we're on the, kind of the same page. Mild traumatic brain injury is broadly kind of defined as being a sort of a traumatically induced physiological disruption of brain function as indicated by a loss or alteration of consciousness. And post-concussional symptoms referring to this kind of broad array of cognitive, emotional and physical kind of symptoms arising, especially in relation after these sorts of injuries. Been lots of good varieties of definitions being used over the years, and these are just a couple. But I think what most people can agree upon is that these sorts of post-concussional symptoms are very common in the first few days and weeks after these sorts of mild sort of traumatic brain injuries or concussions, and that they gradually improve spontaneously with time. And the expectation is that kind of after the first 3 months or so, and you expect people, the vast majority of people will have recovered and be back to kind of where they were before. However, there is this ongoing kind of dilemma that there is a persistent group, a small but significant group of individuals experiencing persistent symptoms as long as 3 or 6 months post-injury. And the idea is that this kind of group of kind of people with persistent post-concussional kind of symptoms have ongoing kind of problems for a number of kind of months or even possibly kind of years post-injury. And that's typically been an issue of clinical law. It's only relatively been recently that we've had some sort of ongoing sort of longitudinal studies that I think have highlighted that there are sort of maybe that this kind of group of people kind of don't spontaneously recover over kind of time, even after the first 2 years. And there's even some evidence from, I think, a German study from the Zumstein et al. That symptoms may even worsen over time. The percentage about how many people have ongoing persistent symptoms, again, is a kind of area of controversy. Again, it goes to a certain extent about how you kind of define these sorts of kind of problems and how you define mild traumatic brain injury. Various estimates really can range between anything from 5 to 25%. But the argument is often couched in these sort of organic and psychogenic kind of terms. This kind of one of the sort of brain-mind kind of gaps. This isn't itself a particularly kind of new or novel difficulty or dilemma. So this kind of, I think it's quite a nice quotation from a 1934 paper. It is necessary for once to abandon the specious dichotomy between organic and psychogenic in an approach to head injury. So this is not a new kind of brain-mind kind of difficulty that we're trying to kind of to bridge. And often how this then sort of trickles down and has an impact in terms of clinical dilemmas and medico-legal dilemmas is often this how we kind of divide up kind of psychological or organic. And again, another kind of oldish kind of quotation from Aubrey Lewis, a Maudsley neuropsychiatrist from many years ago. Again, he's saying that the doctor taking care neither to hunt the snark of physiogenesis to death, nor perfidly to track the red herring of moral obliquity, gold digging or scrim-shanking to its lair. Wonderful kind of language. You wouldn't get that in a journal these days. But I think it gives a sense that these are kind of historical kind of difficulties that have been different clinicians have been grappling with over the years. There are, I suppose, the kind of where we really start as a service. We have a kind of post-concussion clinic that we've been running for about 10 years or so. Is this Orwin Lishman's 1988 model of the relative contributions of different factors over kind of time, which is really about acknowledging that there are going to be direct effects of kind of traumatic kind of brain injury early on post-injury, and that they gradually kind of diminish over time. However, as you kind of go along with time, as time progresses, there's going to be a greater relative proportion of other kind of factors that may be influencing why some people get better and some people don't. And this is kind of variously kind of described as kind of psychological, but it's fairly kind of broad and wide-ranging. And that often where we end up with is this kind of ongoing kind of discussion about to what extent are these residual kind of ongoing kind of problems directly affected by kind of brain injury, do they reflect kind of ongoing persistent effects of brain injury, with the assumption that with kind of mild injuries, the relative contribution is going to be smaller, but whether it looks like this, or looks like this, or looks like this, is obviously kind of one of the kind of moot points. What I'm going to try to do today within the next sort of 20 or so minutes is really just to kind of capture 3 different areas that I think are particularly interesting when it comes to thinking about mild TBI and PCS. Really sort of talking a bit about the neuropsychological assessment of kind of people with kind of mild TBI. Maybe some of the recent developments that we've had in terms of psychological models and kind of explanations for possible kind of factors that may be influencing why people do have ongoing and persistent difficulties, and talk a little bit about the work that we've been doing with a randomized control trial at the Lichman unit, looking at CBT and persistent post-concussion symptoms. What I don't really have time to do today, although it's not to say it's not interesting, is all the interesting stuff around sort of neuroimaging, DTI, all those sorts of things. Some of the kind of the more nitty-gritty about sort of diagnostic issues, and also how post-concussional symptoms necessarily aren't particularly specific and overlap with other areas, and some of the more general discussion about to what extent is cognitive rehabilitation or remediation indicated or useful for people with mild TBI. Okay, so to start off with the neuropsychology of mild TBI, again, there's some relatively consistent findings within the literature. And there have been a number of meta-analyses have been done in the last 10 years, so really collecting a lot of the neuropsychological outcomes data following mild TBI. So here are 4 of them. And that really there's good evidence that mild TBI can have an impact in terms of people's cognitive functioning in the first few days and weeks post-injury, especially around sort of attention and processing speed, memory to a lesser extent. However, these same studies also generally kind of point to the gradual reduction in terms of the impact of these sorts of effects on cognition, and really that you can't really identify any clear impacts of mild TBI, certainly a single uncomplicated mild TBI on cognition really beyond 3 months post-injury. So that's kind of where we're up to really at the moment, and there's an ongoing debate in the literature about the significance of these meta-analytic kind of studies. And really there are sort of 2 camps, mainly North American sort of neuropsychologists that like to take lumps out of each other. But it's a quite entertaining reading if you've got kind of a half hour. But essentially you have one kind of side, which is Erin Begler and colleagues, which are very critical of these meta-analytic studies. And the criticisms are common for meta-analyses in general. Essentially what you do is you lump a whole load of studies together. You've got a lot of heterogeneity within these different studies. You've got sort of different definitions of how mild TBI has been defined, different sorts of injuries, and different sort of assessments that are being kind of used. To what extent do meta-analyses really tell you anything kind of useful? There's no sort of apple and oranges. You're comparing different sorts of kind of things. I think the biggest concern is, that's my taxi. The biggest concern is that these sort of meta-analyses may obscure a small proportion of individuals who have ongoing persistent difficulties. So they obscure a kind of subgroup that have ongoing cognitive difficulties. The rejoinder again is Marty Rowling, again also from the States, and some of his colleagues, is to say, well, you can't have your cake and eat it. Either you take these kind of studies as indicating that there are effects of mild TBI, but just that they can gradually kind of get better. There's also an argument that if anything, because you're kind of combining kind of studies, you're increasing your kind of power to identify ongoing kind of subgroups of people with kind of problems. And if anything, you don't find that the more kind of studies you lump together, the weaker the effects become. And even when you sort of try to fit hypothetical data that has, say, hypothetical data of a subgroup that does have a significant impairment, you just can't get it to fit the data that you see with these sorts of kind of studies. And the kind of comparison is then, well, to what extent do you see cognitive kind of problems, either subjective or objective cognitive difficulties in people with persistent post-concussional symptoms, and what are the explanations for that? So one of the key arguments is really about looking at the other kind of contributory factors, the kind of things that can have an impact on neuropsychological functioning. So as we heard earlier with Andrew, there are a number of kind of different kind of things that one has to think about when it comes to neuropsychological interpretation. And here's sort of data from, again, a kind of another review study that shows on the left-hand side that there are kind of these are effect sizes here. Yes, there are obvious kind of effect sizes in terms of mild traumatic kind of brain injury, which gradually get smaller over kind of time. As you would expect with more severe, more moderate or severe injuries, you get bigger effects in terms of cognition, which are more likely kind of to remain after a kind of period of time. But when you stack up other kind of possible kind of things that might be having an impact on people's cognitive functioning, whether that's people being involved in litigation, effects of kind of medication, comorbid depression, for example, all the way up through to deliberate exaggeration and malingering, you're seeing that the relative proportion, the relative effects of these other kind of factors is potentially quite large relative to any very small effects in terms of mild TBI when you're looking at kind of a number of kind of months post-injury. I think one of the kind of interesting kind of things, I think from my perspective, is when thinking about and conceptualizing persistent post-concussional kind of symptoms, is the extent to which, although there's a degree of ambiguity about the neuropsychological data, what does appear to kind of come out reasonably consistent is this notion that there is certainly a number of kind of people who are reporting quite significant ongoing subjective difficulties with their memory and concentration, to pick up a kind of a question earlier. That it feels like in some ways that characterizes this group of individuals. But the impacts in terms of objective cognitive functioning is a little bit kind of hard to pin down sometimes. It's a very particular favourite study of mine, looking at kind of a concept called diagnosis kind of threat, as a very subtle way in which you can see effects in terms of cognitive performance in otherwise healthy kind of group of individuals. So this study does is essentially it takes a group of people who've had a history of a concussion but are otherwise essentially healthy controls, generally kind of undergraduates in again a North American kind of university. Sometimes they split them into two groups. One group they say, well, we're just going to present you with a neuropsychology data, we're going to provide you with some course credit. And for the other kind of group, because they've completed a pre-screening health questionnaire, they know that they've had a concussion before, and they simply draw attention to the fact that, well, we noticed on your pre-screening questionnaire that there is, you've had a history of a concussion, and concussions can sometimes have an impact in terms of memory and concentration. So I think, from my perspective, I think it's a fairly kind of subtle experimental manipulation. They're not making huge claims about kind of multi-traumatic kind of brain injury and catastrophic impact, but it's just simply drawing people's attention to their history of concussion and noticing that concussions can have an impact in terms of people's cognitive functioning. What I think is surprising is again, when you start to plot the effects of that, just that fairly simple and subtle experimental manipulation on people's cognitive performance, you're seeing, again, moderate to large effect sizes. So for the neuropsychologist in the audience, you're seeing kind of impacts in terms of things like sort of digit span, definite number sequencing, arithmetic, so working memory sorts of kind of processes, even sort of digit symbol as well, so kind of processing kind of speed. You're seeing kind of quite significant impacts just with this very kind of subtle experimental manipulation in a non-clinical group of individuals. So it suggests that there's more that meets the eye when it comes to neuropsychological assessment, again, as we've heard before. Which takes us on, if we're not thinking that there's necessarily an obvious organic or direct organic explanation for a lot of kind of people that we're seeing after mild TBI, what are the other kind of things that might be kind of going on? So because when in the medico-legal section of the day, I'm going to talk a bit about the medico-legal kind of aspects of kind of mild TBI. And again, the kind of debate has been going backwards and forwards within the field. On the one hand, you have a notion of kind of there's kind of deliberate kind of financial incentive if you are involved in a compensation claim, but that's not the whole story when it comes to thinking about medical legal processes. Again, borrowing something from Orwin Lishman here, my quotation here, the repeated rehearsal of symptoms before a variety of audiences, some encouraging, some sceptical, does not help the patient to be clear about what he is truly experiencing. So this notion that the ongoing medical legal process itself may contribute to, or at least kind of amplify, ongoing kind of problems when it comes to post-concussional symptoms. And it's certainly true that your involvement in a medical legal claim, if you've had a mild TBI, is associated with a poorer prognosis. You're more likely to have ongoing kind of problems. And again, another meta-analysis from a few years ago showing a moderate overall effect size. Perhaps concerningly, these effects persist in terms of, in spite of treatment. But that's not to say that kind of involvement in medical legal kind of cases is necessarily synonymous with kind of deliberate exaggeration for financial gains. It's not necessarily say it's all about lingering. So there's an estimate, and I'll probably kind of stress it's very much an estimate. It's basically kind of a questionnaire for a group of neuropsychologists here to ask about what percentage of people they were seeing in their general clinical practice they think are exaggerating their kind of symptoms. And it's around about 8%. Higher numbers when you look at kind of people involved in kind of civil litigation. So 30 to 40% is more kind of common. But there are also issues when it comes to thinking about assessment of effort. Again, as we heard a little bit before, and again, thinking about the association between medico-legal status and poor ongoing kind of poor outcomes. So there's a correlation versus causality argument sometimes. Not kind of studied directly with mild TBI, but I think one kind of quite interesting study here that found an association between medico-legal status after people who'd been involved in RTAs, that medico-legal status was associated with also those who'd had more severe objective original injuries and more significant objective kind of losses. So there may not be kind of a simple kind of relationship between litigation and, as I say, necessarily kind of financial incentive. I think there's also kind of more general kind of psychological aspects of being involved in litigation that I think also interesting to explore. Haven't really been explored kind of in a quantitative kind of sense, but here another kind of neuropsychiatrist kind of writing and highlighting the issue about sort of how medical legal processes emphasize issues to do with culpability and blame, and whether we think that there may be kind of some of the associated cognitions and kind of thoughts and concerns around when you highlight that there is somebody at fault for how I am feeling now, that may itself kind of promote potentially less helpful responses in terms of symptom management. And also kind of even these sorts of tests of effort that have been kind of discussed a little bit, again, aren't purely synonymous with deliberate exaggeration. Again, there are kind of few kind of issues and kind of quirks that come when it comes to interpreting their results. But I think it's also important to kind of stress that when we're thinking about psychological factors, we're thinking much more kind of broadly. It's not just about medico-legal status. So there have been a number of kind of studies really in the last 10 to 15 years, really the last 10 or so years, that really started to kind of put some of the kind of the quantitative kind of flesh in terms of when we say we think that psychological factors are important when it comes to persistent post-concussional symptoms, this is what we mean. So this is one idea, this notion of a good old days bias, that when you ask people with persistent post-concussional symptoms to retrospectively rate the extent to which they had problems with headaches or concentration or memory kind of problems prior to their injury, they tend to remember themselves as being better than normal. This is the kind of study we've done in our service. So what you can see, the kind of controls here are reporting, as you would expect, much less in the way of kind of current post-concussional kind of symptoms compared with the kind of PCS group. When you ask PCS group to retrospectively kind of rate their kind of symptoms compared with either kind of the control's current symptom ratings or control's retrospective kind of ratings, you're seeing that kind of PCS remember themselves through rose-tinted spectacles. What's also interesting to notice is actually there is a slight difference here with the controls, that our control group remember themselves as being slightly kind of better in the past than they are now. So the extent to which kind of there's maybe kind of a general tendency that we all have to remember the past in rose-tinted spectacles, at least when it comes to post-concussional symptoms. But this is a phenomenon that seems to be exaggerated for people with persistent difficulties. Again, other kind of factors that are kind of, we think are possibly kind of interesting and important. Kind of this is data from another kind of study looking at more kind of general kind of beliefs about emotions. So this is the snappily named Belief About Emotion scale, originally developed for a group of people with chronic fatigue, where again there is often a lot of kind of interest and debate and discussion as to what extent psychological variables and psychological factors are important in terms of why people have ongoing kind of problems. And really represents the kind of the beliefs about the unacceptability or experiencing and expressing emotions, especially negative emotions. So a couple of kind of sample items here. What's kind of interesting is when you ask the kind of same experimental design, asking people with persistent PCS and controls to retrospectively kind of rate these sorts of kind of beliefs, the PCS group remember themselves or kind of rate themselves as having more of these sorts of kind of beliefs about the unacceptability or issues about experiencing or expressing negative emotional kind of states, even compared with controls. So that whether that's a possible kind of pre-existing kind of possibly kind of trait risk factor, it's a possibility. One of the we're thinking about kind of going back and having another look at. But I think for my money, the most interesting kind of work that's been done looking at psychological factors is work around illness and injury perception. So this is kind of borrowing very much from sort of health psychology kind of models of how people adapt to, say, diabetes or other kind of physical health complications. And really a pair of, I think, quite nicely kind of designed studies here, one by Whitaker and colleagues, where you ask people essentially, to what extent do they expect their injury to have significant ongoing impacts fairly early on. So they were asking kind of people essentially within the first kind of week to 10 days post-injury, and then looking to see whether people did have ongoing kind of symptoms at 3 months or 6 months with this kind of other kind of study that was done down in Southampton. And perhaps, well, I suppose not necessarily paradoxically, but essentially your predictions, or kind of the predictions in the group of kind of people who've had mild TBIs, did actually predict whether they did have ongoing kind of symptoms at 3 and 6 kind of months post-injury. So kind of essentially with these early kind of concerns about the consequences of injury and predictions about the timeline of recovery seem to be kind of predicting later kind of recovery. I think what's particularly interesting, especially with the Whitaker study, is essentially all of the variants in terms of predicting kind of post-concussional kind of symptoms at the kind of later kind of time point seem to be kind of funneled through this kind of this notion of illness and injury kind of perceptions. There was no additional contribution when you came to looking at anxiety, depression, PTSD, injury severity. So I think that's kind of interesting, and I would suspect a lot of where the field will be going in the next few kind of years, what I suspect be kind of looking at these sorts of injury beliefs, and again, how this kind of relates to treatment. So another kind of final historical quotation for the day. I think it's, again, not novel to kind of think that psychological treatments may be interesting and relevant when it comes to thinking about approaches for dealing with kind of persistent difficulties after mild TBI. I like this, again, a little kind of phrase here about the skill with which it is conducted Harmful probing is, of course, unskillful as superficial dabbing can be, or crude ploughing and plugging. So if for the psychologists in the audience, if we can avoid probing, dabbling, ploughing and plugging, we're on the right sorts of track. And again, it's not this necessarily here, again, probably as a cognitive behavioural kind of therapy fan, this kind of sense we're sort of striking some sort of kind of psychotherapeutic balance between a sort of in-depth psychoanalysis or kind of something that approaches a casual chat. There are a number of kind of treatment studies that have looked at persistent PCS, but really have focused more on the early information, early kind of reassurance in terms of prophylaxis. So there's quite a nice review in JNNP by Elsie and colleagues. That there's some good evidence that these sorts of prophylactic education information approaches can be helpful in terms of reducing persistent symptoms. Certainly there's also a bit of evidence that because so many people are getting kind of better without kind of necessarily any additional kind of input, that there may be some additional kind of benefits when you sort of target at-risk individuals, so maybe kind of people who have a pre-injury, a kind of a pre-morbid kind of psychiatric history, maybe sort of targeting those individuals in particular may be kind of helpful. Certainly, historically, it's also been the case that when you have persistent symptoms, they've generally been viewed as being difficult to treat or certainly resistant to treatment. And there's, paradoxically, again, very little evidence to back that up. So as far as I can really kind of tell, in terms of kind of very obviously and directly relevant kind of studies, just this one RCT, again, by Lana Tiersky and colleagues, that looked at a fairly intensive combination of both kind of CBT and cognitive rehabilitation techniques, amounting to about 55 hours worth of kind of client-therapist contact time plus homework, so kind of really kind of quite intensive. But they did demonstrate some improvements in terms of not just symptoms, but also in terms of some performance on neuropsychological tests. Which brings us to the RCT that we've been doing at the Lishman unit for what feels like a very long time indeed. Having started when I qualified in 2002, the fact we're just finishing writing it up now gives you kind of a sense of how long it's all taken to get off the ground and run. Essentially, it's a fairly simple randomized control trial looking at 12 sessions of CBT. Everybody that we saw was at least kind of 6 months post-injury, and more so typically, I think our average kind of length of time post-injury was around sort of 2 years. The CBT itself was fairly kind of flexible. One of the issues with PCS is this heterogeneity of symptoms that you kind of get a variety of problems with, from its headaches to fatigue to depression to anxiety. So it does mean that the kind of the CBT itself does need to be reasonably flexible. I won't talk about the huge intervention, just the results really, and some of the analyses. So the CBT group, so when you look at the kind of persistent post-concussional kind of symptoms, this is the Rivermead PCS questionnaire. Our intervention kind of group show a nice decline in terms of post-concussional kind of symptoms, which is great, except when you look at it compared with the waiting list control group, who also show a paradoxical improvement in terms of their general post-concussional kind of symptoms, which is obviously good for them, but it's slightly kind of mysterious from a methodological perspective. We wonder what's going on there. We used another kind of, one of our other kind of primary outcome measures was a semi-qualitative quality of life measure called the QOLAS. This does show a much more clearer impact in terms of the CBT improving compared with a slight improvement in terms of the controls. So it appears that we got some potentially some mixed kind of findings, but some positive kind of findings that CBT appears to be kind of helpful in terms of improving kind of symptoms, but kind of the outcomes variables, the outcome measures seem to kind of vary slightly in terms of what they're telling us. And one problem we did have, more from a methodological perspective, is actually it takes longer than we expected to complete the 12 sessions of CBT. So essentially our waiting list group were being sort of held in their waiting list group for a slightly shorter period of time compared with the length of time it took to complete the CBT. So what we had to do is essentially go back and reanalyze our data, basically kind of co-varying for the effect of kind of the impact of the kind of the interval between the initial assessments and the kind of the post-treatment assessments. Essentially, one of the concerns that we had is because we spent longer treating the people with persistent PCS than with the waiting list kind of control group, was it simply that we were seeing some sort of spontaneous recovery effect happening. In fact, we didn't find that at all. So all our significant results remain significant, so the specific CBT effects appear to be ongoingly significant, but we also started to see then a treatment effect in terms of the general kind of post-concussional kind of symptoms. We also saw, again, with this secondary analyses, so secondary outcome measures, again, this sort of additional analyses highlighted other improvements in terms of anxiety, fatigue, and anger, although not necessarily depression or PTSD. Just to kind of highlight what that means, or what we think that kind of means in practice, is this kind of graph here. So what we've done here is essentially divide up the CBT treatment arm in two halves, the kind of the group who completed their CBT the fastest and the group that completed their CBT the slowest. And what you can see here is it's the group of individuals that can complete their 12 sessions in a shorter period of time are the group that showed the greatest recovery. Quite what that's about, I couldn't tell you for sure. We wonder whether it's something about either the treatment intensity, so the extent to which it's all very well having 12 sessions of CBT. Everybody's getting 12 sessions of CBT, but you need to have those 12 sessions of CBT fairly kind of close together, either on a weekly or a fortnightly kind of basis, for it to be helpful or effective. The other thing we did wonder about was whether this is also kind of an effective treatment engagement. If you're presenting kind of a psychological model or an explanation, for some people that may kind of fit and they kind of understand the kind of model if they feel they can work with it. For other kind of people, that may be more of an issue. But there's certainly variation in treatment response that we're not too sure about. Another kind of final kind of area that we were looking at and interested in was the different kind of factors that moderated sort of treatment effects. We had some sort of specific kind of ideas about this because we were looking at a range of different people with different sort of injury severity. So we were seeing people with some more moderates of TBIs as well, because we were seeing a number of kind of people who were involved in medical legal claims or had previously been involved in medical legal claims. We wanted to have a look at whether those sorts of things did have an impact in terms of people's outcomes with CBT. The other issue that we had was also thinking about sort of comorbid anxiety and depression. One of the kind of questions I had at the start of the trial was really to what extent, if you're seeing somebody with an obvious sort of anxiety or obvious kind of depressive symptoms at the start, does that make it easier to engage in a psychological therapy because you have kind of an easier kind of framework in which you're kind of working? Actually, the answer to that was no. If anything, it's the opposite. So here, this is kind of people kind of divided up according to the HADS, a kind of common anxiety and depression measure. What you're kind of seeing is a trend for the people who are neither anxious or depressed. They start out as being kind of slightly kind of better than their depressed and anxious colleagues, but they show a larger improvement in terms of the QoLAS compared with. So again, slightly kind of unanticipated, kind of, but not inexplicable kind of finding. But I think for my money at least, it suggests that what you're sometimes trying to do with CBT it's not just about sort of trying to sort of treat comorbid anxiety and depression or sort of treat obvious comorbid psychiatric targets. There are other kind of aspects of kind of CBT rather than just doing that. Very kind of simply, all the other kind of factors that we were interested in terms of moderating kind of treatment response, so injury severity, length of time since injury, medical legal status, none of them had any kind of obvious impact in terms of dictating treatment response, which I think, again, has an interesting and useful kind of message, is that certainly for people we're seeing maybe some 2, 3, sometimes 4 years post-injury, maybe there might be kind of a clinical intuition that is going to be harder to engage them in some sort of kind of therapy, or they're going to be less responsive. But the data that we have from the trial suggests that's not actually the case. And again, the issue about kind of medical legal kind of status, I think the lack of an association between that. We've looked at this kind of two ways, either people who are involved in current ongoing medical legal kind of claims or had previously been involved in medical legal kind of claims. Again, no impact in terms of their treatment response. One has to be a little bit cautious about these data. It's just done with the 25 of individuals that we saw within the treatment arm. So the kind of power isn't kind of great, but I think it's kind of interesting. It's interesting just to note that I think it hints that although these kind of factors may have an impact, they don't have a huge impact. We also had a look at the unanticipated improvements on the waiting list kind of group with our post-concussional kind of symptoms. And again, we don't find any impact in terms of injury severity or medical legal status. Again, not too sure what that's about. Question that often kind of crops up, well, how big are these improvements that we're kind of seeing within the CBT arm? Certainly when it comes to the general kind of post-concussional symptoms and quality of life, you're generally kind of seeing kind of fairly kind of healthy size to effect sizes when you're comparing pre-treatment to post-treatment. So those with the sort of stats, you're seeing the moderate to large effects on quality of life, post-concussional symptoms and fatigue. But I think it's also important to note that kind of CBT is not a panacea. Not everybody kind of gets better. So when we look at sort of trying to divide up the kind of CBT group according to people who maybe fall below a kind of a fully kind of symptomatic kind of cutoff, we're maybe getting sort of say a quarter of the kind of this CBT arm, essentially kind of a symptom kind of free or having very kind of low levels of kind of symptoms at the end of the kind of treatment. And probably another kind of quarter or so are showing reasonable improvements on the PCS kind of questionnaire, but it leaves maybe kind of a half or so kind of people that aren't showing fantastic responses in terms of their overall post-concussional kind of symptom kind of levels. So there are still some outstanding issues with the clinical trial. Important to note is like all these sorts of things, we were trying to do this in a real world sort of setting, so it's not methodologically kind of perfect. There are some ongoing issues about generalization. We also have some ongoing kind of planned analyses, so we're quite interested to see what happens to the waiting list kind of group after they've had their CBT. And more general kind of questions, I think, also about how you kind of structure kind of CBT with kind of people with persistent PCS, where you deliver it. Not everybody has access to a kind of specialist kind of post-concussion clinic. Is this something that should be kind of offered through kind of community brain injury teams? But as we've heard this morning, it's not always the case that the community brain injury team exists or that they have access to a neuropsychologist. Okay. So, just to summarise, multi-TBI, in my opinion, I don't think it's neuropsychologically catastrophic, but neither it is without impact. But there are often sort of rather kind of difficult, knotty issues when it comes to interpretation of neuropsychological assessments. Psychological models appear to be well placed, certainly as significant factors that appear to kind of explain a large chunk of the variance in terms of why some people do recover and some people don't recover after multi-TBI, but it's to say it's not synonymous with medical legal status. And that ultimately change is possible in symptoms, both in symptoms and quality of life. Even on a waiting list, but it's better with CBT. But I think one of the interesting kind of things, certainly with our kind of study, is really kind of noticing that there is this kind of variability of treatment response, which I think most kind of clinical psychologists who've kind of seen to people with persistent PCS and tried CBT, I think it's one of the kind of common factors that kind of people identify, that there's quite a bit of variability in treatment response, but it doesn't appear to be kind of necessarily sort of tied into obvious kind of things like medical legal status or injury severity or length of time since injury. Okay, just to thank my colleagues, Simon Feminger, who was the neuropsychiatrist at Maudsley, Richard Brown and Lucy Herman at the IP. That's it.